Good morning, good afternoon, and good evening for everyone. I am Dr. Mohamed Mansour. I am the Director of Eastern Mediterranean Public Health Network, Infinite. I want to welcome you to the first webinar for this year. Eastern Mediterranean Public Health Network, Infinite, has been regularly organizing these series of webinars for more than a year. Rich sessions and in-depth discussions were held about different public health topics encountered around the globe and in our Eastern Mediterranean region, especially the COVID-19 pandemic. We hope this year will be marked as a year for more progression and action toward the pandemic end and better health for all. We are now noticing that cases are rising again in majority of our countries, especially after declaring Omicron as a new SARS-CoV-2 variant in November 2021, and many people are rushing to book their shots of the vaccine. By the beginning of 2020, there are questions that feel more pressing than ever. When will COVID-19 end? What will be its fate in 2022? Could the COVID-19 pandemic burn through the human population and then evolve to become weak enough that is no longer a pandemic level threat? Could it become a seasonal issue that can be controlled by yearly vaccination? What about Omicron? Is it less severe? Or can we compare it with Delta? Do we witness a combination of two variants, Delta and Omicron? Could wealthy nations conquer COVID-19 in their regions through vaccination or new treatments, and then consider the pandemic ever while it's growing in lower income countries with low vaccination rates that we witness? What about our previous experiences? Do we consider our previous experiences to currently managing the current situation in our regions? How we can better document our experiences in our region and elsewhere? Looking back in the history of pandemics and ends in one of two ways. Either we close off all chains of transmission and drive cases to be minimal, as with Ebola epidemics to date, or the disease become an ongoing part of the infectious disease landscape, or endemic, as tuberculosis is today. Experiences from the previous influenza pandemics would suggest also that barriers more from pandemic pathogens to endemic diseases within a year and a half or 2 years of emergence. Data so far are mixed on the severity of the disease that's caused by the new variants. Some early findings have pointed toward a mild clinical course, while other evidence has suggested that Omicron may lead to more frequent hospitalization in children than other variants do. We should not minimize the effect of the new Omicron variant. The new variant posed many challenges by its high transmission levels and corresponding burden on public health system and health service delivery in general. Today, during this session, we will share the experts' expectations regarding the fate of COVID-19 during the year 2022. I would like to welcome Dr. Faris Salami, who will be our co-facilitators for today's webinar. Dr. Faris is a public health expert and associate professor at Baghdad University, Iraq. Dr. Faris, the floor is yours, please.
Thank you so much, Dr. Mohamed, and welcome everybody. Good afternoon, and most welcome in today's webinar. In fact, very recently, indeed, in January 13 this year, the emergency committee convened by the WHO Director General under the International Health Regulation held its 10th meeting regarding the COVID-19 pandemic to set a vision for how to optimize the 2022 response to the pandemic. In fact, the emergency committee agreed that the COVID-19 pandemic still constitutes an extraordinary event that continues to affect the health of people around the globe, pose a risk of international spread and interference with international traffic, and require a coordinated international response. Today's session will offer a space for speakers and audience to reflect on the latest information available about vaccine rollout, variants of concern, and disease progression, covering various aspects really of the pandemic, including epidemiology, vaccinology, control measures, and the future of the disease. So the objective of this webinar that we are going to cover, inshallah, will be to highlight the world experience with the COVID-19 pandemic over the last 2 years, to discuss the expected changes in the epidemiology of the disease in 2020 and after, and thirdly, to predict the long-term impact of the pandemic on the health system and people's life. Before giving the floor back to Dr. Mohaned to introduce the first speaker, Her Excellency Dr. Maha Rabat, I would like just to attract your attention, my colleagues, to 2 points. Number one, if you have any question, you have a question and answer box at the bottom of your screen. So if you have any question, please put it there, and we can respond either live or after completing all the presentations. And secondly, this webinar is being recorded, and will be available for all the participants following today's webinar. Dr. Mohaned, the floor is yours to introduce Her Excellency, please.
Dr. Mohammed muted.
Sorry, I was muted. Sorry for that. So it gives me a great pleasure to welcome our first speaker today, Professor Maha Rabat. Dr. Maha is a professor of public health at Cairo University. She is a World Health Organization Director General Special Envoy on COVID-19 for Eastern Mediterranean region and former Minister of Health in Egypt. Professor Maha will give us an overview of the COVID-19 pandemic during the years 2021. Dr. Maha, you have 20 minutes, and it's really our pleasure to have you with us. You have 20 minutes, and the floor is yours. Please, Dr. Maha. Thank you.
Just a second.
Take your time.
Okay. So thank you very much, Dr. Mohaned, for the kind invitation. Your Excellency, Dr. Haytham, Dr. Amrish, Dr. Faris, Dr. Mohaned, and thank you very much for the invitation to participate in this webinar. It gives me great pleasure to be talking about or just discussing with you and presenting some of the learned experiences of the past 2 years as per the COVID-19 pandemic, not only on the regional level, but mostly on the global level, because what is happening on the global level really reflects itself on regional and national levels as well. So now we are at a time that marks 2 years since the declaration of COVID-19 as a public health emergency, followed by its declaration as a general pandemic, which is highest level of alarm under international law. So when we're talking about the past 2 years, so it's like, what is the global epidemiological context that we are experiencing? And what are the factors that are still up to this very day driving the transmission? And a very important aspect, which is a cause of many debates in this time of the pandemic, is the status of the COVID-19 vaccines that I would like to relate or refer to as well. So beginning with less than 100 cases in China, to reach at this time, to reach about 350 million reported confirmed cases of COVID-19 worldwide, and more than 5.5 million deaths from almost every country of the globe. Well, as on the regional level, we reached 18 million cases with 65,000 reported deaths, approximately 65,000 reported deaths, but we really have to underscore the relevance of reporting. We know that all of those numbers, even at the global level, are underestimated. So since Omicron, which is a variant of concern, was first identified a few weeks ago, the number of cases of COVID-19 has been increasing dramatically, largely in nearly every country, since it has a significant growth advantage with a less risk of severe disease than Delta. However, it poses a risk as well. And as well, those increased numbers, they overwhelm the health systems and all of the other relevant systems as well. And since like few weeks ago with the Omicron spreading everywhere, we find that more than 80 million cases have been reported to the WHO, more than the numbers that have been reported during 2020 itself. So far, the explosion in the cases has not been matched by a surge in deaths. However, deaths still occur. And it's really dramatic to count deaths and say by numbers, but we have to realize the implication of the death of every one, people who could have been saved from this fate by many of the actions that could have been undertaken. So especially in Africa, we find that we have a surge in deaths, the region with the least access to vaccines. And this really unveils the challenge imposed by the inequities and by the vaccine inequity, and we're going to come to it later on. So the pandemic has been a severe disruption to the health systems, to the economies, to the societies, to the education, transportation, to everything all over the world because of lack of preparedness, but because as well of the unequal responses in different countries. And all of this has led to unequal outcomes, unequal results, with populations all over the globe disproportionately impacted. The disparities here are showing clearly in many of the outcomes that we see. And since the pandemic, and with the generation of the evidence, the knowledge for the preparedness, the readiness, and much progress has been made with the investment in public health, health security, surveillance, data collection, data sharing, and support of the frontline workers, as well as diagnostics and treatments, the technologies, the innovations to fight and deal with the virus, things that have developed at a pace which has never been seen before. And all of this has been due to the collaboration, the solidarity. But now that we're talking collaboration, solidarity, we know that we need to do more. More is needed with leadership, solidarity, collaborative global actions, which should be flagged at the forefront of the response. We need to share more of the doses, more of the resources, the technologies, the data, the research results, and we need to be transparent in a way that would really affect or that would really enhance the trustworthy response of the population. And we need to address all of this issue globally and at the regional and the country level, but we need to have a global perspective and oversight of how things should be managed. And again, we're going to come to the inequity part and the nationalism of the different interventions that are being undertaken. So in the past 2 years, there has been like what we can say, like an enhanced process for integrated pillars to be undertaken in order to be able to end the acute phase of the COVID-19 and to build the health system resilience and readiness. So we were talking about health systems which were not supportive of emergency actions to transfer or to a transition to health systems which with resilience, which are able to accommodate changes, which are able to integrate interventions, and which are able to function normally with disrupted services that have been underlined or unpacked during this pandemic. So there were integrated pillars with which many of the countries were attempting to overcome the acute phase of this pandemic. So in order to optimize the response, there were these issues or those interventions and strategies and policies that were directed to reducing the exposure to the virus. And this would support, with the support of policies, integrated modules, targeted addressing risk factors, all of those issues. And it was followed by issues and intervention strategies to reduce the transmission. And so reduce exposure, reduce transmission through the implementation of selective and evidence-based public health and social measures. So what here is really important is that many of those strategies were based on scientific evidence. And up till now, the scientific evidence is the same. It hasn't changed. Maybe some added data were there, but the evidence and the science are still there, things that we should be building upon and should not neglect our knowledge and our experience in handling them. Then there was this, again, this response to protect the vulnerable, the higher risk groups, the higher age groups, those with non-communicable diseases, and as well to reduce the morbidity and mortality by making available all what is needed for hospitalization, for the treatment, for the oxygen ICU, and as well for the protection, training, and making available the health workforce. And at the same time, when talking about whole of government, whole of society, comes the role of strengthening the communities, engaging and empowering them for the implementation of the known public health measures. In order to be able to end as well this acute phase and to move to the emergency part, to ending the public health emergency part, there were two emphasis on some of the pillars, as I mentioned before, but what is there again is the increasing of the COVID-19 vaccination coverage. And this is an issue in itself, because when the vaccines were developed, deployed, and used, they were thought to be the golden star of the interventions and the response, and this is true, but as part of collective actions that have to be implemented together. So increasing the COVID-19 vaccination coverage to each and everyone in the world, and at the same time is to reduce the transmission, as we mentioned before. But still, with all of those interventions, we find that there are challenges that have been met and are still imposing a challenge to the proper response for ending of the pandemic and the emergency. Because if we are able to reduce the spread of the disease and maintain it at a lower level, and to significantly reduce the severe disease and death, then we can end this emergency. This is what we aim at and what we are planning for. So we find that despite all of the actions that have been undertaken at the global, regional, country level, there are challenges that persist due to nationalism, due to the politicization, due to many other challenges, like, for example, inconsistent adherence to protocols and public health measures. And we know that for many countries, either due to the fragility of the systems, due to the fatigue, due to the disruption of the economic and the social pattern of the lives, we find that there is inconsistent adherence to those protocols. Particularly, this led to the emergence of new variants of concerns. And we're also dealing with poor access to vaccines, to diagnostics, to treatments and oxygen. They all pose a challenge, particularly for lower and middle income countries. And these all issues collectively, they jeopardize the chances of recovery as well. As well, there is the rapid transition between mitigation interventions. So we find that at one point we're doing lockdown. The second phase, we are just removing all the public health measures that are needed. So this, in a way, really disrupts how people and how systems are responding to the needs as well, and the imposed challenges and opportunities. There is weakness of the health systems and a fatigue affecting the responses. The vaccine inequity, the emergence of new variants, which if we're talking about new variants, this is like a position of all viruses, but they are given, this virus is given the chance for to really change and for the evolving of the virus and its variants. So the virus is still evolving, and we are giving it this chance. In a way, we are responsible for what is really happening. And then we find that there is resistance, community fatigue, infodemics, misinformation, changing guidance with no evidence. This is a real challenge that we should be really looking forward to how to counteract and to overcome. And then we find that the accessibility, affordability of the medical measures, challenges to maintain the community engagement, challenges in even the availability and the number of the tests that are available, where they should be tested, where the tests should be used, how they should be used, the interpretation, and the need for the adapted monitoring and control strategies as well. So now when we come to those challenges, and we know that if we think about those challenges and many more, then we know where do we stand from the pandemic, and where do we stand from what we have learned in the past 2 years, and how we need to rethink our status in the coming month, year, maybe. However, this is a point that needs to be discussed. So when we come to the vaccination here, we recommended with the real the progress in the vaccine development, deployment, distribution, and there are certain caveats and gaps that still exist. And while the current vaccines continue to be effective in reducing the risk of the severe diseases and death due to COVID-19, they do not completely eliminate the risk of transmission. We have to bear this in mind. Being vaccinated does not mean that there is the eliminated risk of transmission. A global, targeted, integrated strategy is really needed at this point for assuring the protection of the high-risk populations, for the health workforce, and for particular focus on countries with low vaccination level. So what is the status of vaccination today? We have 17 COVID-19 vaccines in use. They are deployed. 9.9 billion doses of COVID-19 vaccines have been administered globally as of January 24th. 28 million doses daily administered all over the world. However, with disparities, as you all know, due to the politicization, nationalism, and all of those issues, and due to the absorptive, many other challenges as well, not only for the production and the number of the supply, but as well to the absorptive power of many of the countries as well. So as it stands, we have now 86 member states across all regions of the world. They have not been able to reach last year's target of vaccinating 40% of their population. 34 member states, most of them in Africa and Eastern Mediterranean, they have not been able to vaccinate 10% of the population. So what we know now is that 84% of the population of Africa up till this date have not received any COVID-19 vaccines. And this is a challenge in itself. And as I mentioned before, we have different countries, 14 in Europe, 19 in the AMR, 11 in the Eastern Mediterranean region. They haven't reached the 40% target. And we know that we need to reach the 70% target for all countries and for all regions and on the global level by mid-2022. But it's really very frustrating to know that in high-income countries, administered 14 times more doses per inhabitant compared to low-income countries, inequities. So the COVAX and the other international platforms, they have worked so hard in order to supply some of the needed doses of the vaccines to 144 participant countries, and 1 billion doses they have been shipped to those participants. But this is not acceptable if we're talking equity, if we're talking collective actions, if we're talking solidarity and global coordinated efforts in order to end the pandemic and the emergency status. And we said we cannot simply end this emergency phase unless we bridge those gaps that are present in the vaccine, in the diagnostics, in the management, the drugs, the medicines, I mean. So all of those issues, and for the implementation of the known protocols, we have to have this. And so there is no path unless we achieve our target of vaccinating 70% of the population in the middle of this year. And please note that vaccines are only one of the needed tools. They are not the only tool. However, they have gained much attention because of the inequities that they pose, and because of, as we say, no one is safe until everyone is safe. So we have to have this uniform coverage for each and every one on the globe. So where are we now on this pandemic timeline now? We have lots of uncertainties up till this very moment. So around the future evolution, there are much uncertainties, and we all know that it is going to be endemic. The endemicity is there we can see it, but it is still far away. How long we can reach it still is a point of debate because of the different changes, the different surges, and the different scenarios that are being undertaken as well. And because of the widespread vaccination, but still the inequity part and the discrepancy, and as well the affection of the strategic use of the tools that work. We know that there are tools that really work. And we always say we're not safe until each one of us is safe. We have to believe in this. And that's how this is our way forward, in order each and every one of us will take his part, his responsibility in being part of this response and of ending the emergency and the pandemic. So if we ask ourselves, where are we now? Then if we know where do we stand, what we are doing, how we are faring, then we would know where do we stand from the pandemic. And to end the emergency, we need to reduce the spread and to maintain it at a very low level and significantly reduce severe diseases and death. Is this what we're doing now? Or are we really failing in some parts of the world? We're failing at certain levels. These are the questions that we have to answer now. So what we see now, we see very much, we are in the middle of the pandemic. We continue to have intense global spread, including unexpected surges in many places of the world. So factors are still continuing to drive the transmission as we are talking now. The virus continues to evolve, more transmissible variant, highly susceptible population, and so these are challenges, and it really draws the picture of where we stand now from the pandemic. So saying this, we still have a long way to go. We can't see the far end, but we are not there. We can see the far end, but we are not there yet. However, progress has been made, knowledge has been built, innovations have been produced, and countries are responding, however, differently as we are talking. And so to defeat the pandemic, we need to exercise a package of actions at different levels with solidarity, leadership, and at the same time, to build forward better, we need to push and to urge the societies as well to be part of this response, not only the governments, but as is mentioned, whole of government, whole of society. And we must reflect on what to do differently, not to change everything, but to transition in a different way in order to respond to the emerging needs. We should not be abandoning what we have learned, but we adjust to what we want to do. Adjustment is different than abandoning or changing. And the last thing I would like to mention here is that, as Dr. Tedros just mentioned, is that his warning that conditions remain ideal for more coronavirus variants to emerge. He says that it's dangerous to assume Omicron is the last one, or that we are in the end game. Dr. Tedros also said that the acute phase of the pandemic could still end this year if some key targets are met. And it's true that we will be living with COVID for the foreseeable future, and that we will need to learn to manage it through a sustained and integrated system for respiratory diseases. To help for the future pandemics, Dr. Tedros said, learning to live with COVID cannot mean that we give this virus a free ride. It cannot mean that we accept deaths. And it does not mean that being endemic, that it is going to be less severe, but we should be expecting surges as we're moving ahead. But this is what I'm saying, not Dr. Tedros. So at the end, I'm just leaving it here. And thank you very much for giving me this opportunity again. And again, Omicron is not a mild disease. It's not the common cold. It's different than the flu, but it is a less severe disease than Delta, but it is still severe and overwhelms the health systems. Thank you very much.
Thank you very much, Professor Maha. This is very informative. talk and highly appreciated. We will leave the questions to the end, but I am trying to summarize the main point that Professor Maha mentioned, that we should not underestimate the Omicron. Omicron, it's not mild or simple disease, but we have to be careful with Omicron. And the other thing that maybe the other important message Professor Maha mentioned is about the equity of vaccination, and this was a big challenge for the globe, and it's something ethically we have to reconsider, because we see the inequity of distribution of vaccine all over the world, where we see, as Professor Rabat mentioned, that some countries in the Western countries, maybe they keep the vaccines. However, Africa, for as example, the prevalence or the percentage of the coverage of vaccine coverage is less than 10% of the world. So vaccine inequity is an issue that if we need to fight against, this issue. Dr. Maha also linked, the deaths and number and percentage of diseases in Africa compared to the vaccine. And I think this is very important concepts that we need always to work on, as vaccine equity. And as WHO said, we are not safe until everyone is safe. I think this is something that we need to keep believing in, and we keep to mentioning, and etc. So Professor Maha also emphasized on the importance of transparency and collaborative actions, sharing resources and information. And I think these are very important message that we need to work on it. And Professor Maha also mentioned the main challenges in the previous 2 years is related to nationalism. And, we need to work at the global level, we need to work collectively, and we need to be more opening to each other. And I think, Dr. Maha also mentioned very important message related to the health system with the resilience, and the health system with the emergency situation. And this is a big question, and a big topic that we need always to emphasize on, how we can make our health system more resilient to what we are. Professor Maha sent a very clear message today in our webinars related to relying on evidence-based medicine. We need evidence to be there. We need more science. We need more, documentations. We need to be best practices there, and this is very, very important to us. And if you allow me just to finish with the very important message Dr. Maha sent. It's the importance of engaging and empowering and the communities. We need to work with our communities, and we need to make, they are our partners in fighting this disease, and etc. So solidarity, the word that we always love to end of this, and I think it's very important also, key message that we need to emphasize on our today's seminar. So thank you very much, Professor Rabat, for your very informative, very meaningful messages that you sent to our region today and the globe. And if you allow me to move to Dr. Faris for continue on the session. Thank you very much.
Thank you.
Thank you, Dr. Mohammed, and thank you, Dr. Maha, for the great points that you had raised really, and the nice summarization again that came from Dr. Mohammed for the many points that you had raised. Thank you so much. And now allow me to introduce our second speaker, Dr. Amrish Beju. Dr. Amrish is the director of the MSF Luxembourg Unit on Humanitarian Operational Research and Epidemiology, and elected president for the European Program of Intervention Epidemiology Training, EPIET, alumni network. He's also an assistant professor at the London School of Hygiene and Tropical Medicine. Dr. Amrish will talk about what changes to expect on the epidemiology and control measures of the COVID-19 pandemic in 2022 and beyond. Dr. Amrish, you have 20 minutes for your presentation, and later on, hopefully, we will address all the questions that can be raised. The floor is yours, Dr. Amrish.
Thank you. And I hope you can see my screen okay. Okay, perfect. Well, I think Dr. Maha made such an excellent presentation that I could say I've not much to add, but what I maybe could say is that I fully agree with every word that she said, which means when there is scientific consensus, it's probably true what we are saying here, and that people should take these messages very seriously. It's indeed 2 years into a pandemic, where I at times as a public health professional felt very disappointed and not being listened to, sometimes by our political colleagues, but also the tensions, but also having the respect that yes, public health is important and we try to protect the health. But when we are protecting health by measures, we can also cause damage, and finding that balance between measures and protecting health is incredibly important. Now, as was mentioned, I work with Doctors Without Borders, who you might know as an organization that mostly acts in the most difficult types of emergencies. And these are also typically the types of emergencies where the basic measures as we know them are not always easy to take. When we talk about we need to keep distance, how can you keep distance if your average household member size is 6 to 8 people? How can you keep distance if you live in a crowded refugee camp? How can you wash your hands if 60% of the population doesn't have access to clean water? So in many ways, when we talk about measures, we also need to be respectful always that being able to adhere to measures also is a certain privilege, how weird it might sound for some populations on our planet. Now, I actually wanted to speak also about the certainties and uncertainties, because like Dr. Ma also said, we are coming to a stage where more and more people ask, is this the end game? Is this pandemic now over? You can read it in many newspapers. And I think in many ways, it's what we hope. And sometimes what we hope, it becomes reality, but it actually isn't. And we have seen that, of course, in this pandemic in several times, where new variants really changed the picture. And I kind of want to reflect a little bit on that. I left a little bit the efficacy of measures and things like that outside this presentation because there are no randomized controlled trials for real life situations to the extent that we exactly know what the impact is for keeping distance to each other or the effect of mask use, for example. So maybe, as the colleagues of WHO have done so nicely during this pandemic, provide us with the weekly global pictures of what the situation is. And what we see is that actually in all regions, indeed, due to the Omicron variant, cases are increasing. But in countries with higher rates of vaccination and countries that started the booster campaign early on, we do see a further disconnect between infections and severity of disease. But again, that does not mean that we're speaking, like everyone would agree here, about a mild disease. Not at all. It means the following. It means that the vaccines work. We see that people who are vaccinated way less often end up in the hospital. And with the hospital, I mean regular wards or intensive care wards compared to those unvaccinated. And indeed, the effect is even more visible for those who manage to be privileged enough to have access to a booster injection. The current boosters are not perfectly adapted to the Omicron variant. And we know that the Omicron variant has 30+ mutations that affect immunity. But it did give the immune system an extra reminder that it needs to be on the lookout. So yes, it's important to take that booster if you have access to it. The vaccines that will be fully adapted to Omicron will be getting on the market in April. And unfortunately, we know where in the market they will end up first and where in the market they will not end up sufficiently in time. But it will mean for those who have access to it, a better protective effect and less of risk again being hospitalized. Also, what is currently in development, of course, better treatments next to vaccines. People who are in a high risk category, who can take these treatments at an early stage, have less risk of severe disease being developed. It also requires this discussion, which was done by Epicenter, one of the other research branches in MSF by Professor Yap Yoom, who did a lot of seroprevalence studies in different countries in the Africa region. And he said that many people already have gotten COVID by seroprevalence studies, but it didn't necessarily result in severity of disease. And that, of course, has to do in some cases with the fact that there are differences in risk profiles. And we know that severity of disease is very strongly linked in many cases with age. We also know that severity of disease is very often linked to the prevalence of non-communicable disease. And there's heterogeneity in that. That sometimes explains the differences, of course, of impact also in different regions of the world. Again, that's no excuse for vaccine equity at all. But for us as public health professionals working in regions where COVID is a problem, but many other diseases are severe problems as well, and resources are not enough to cover all the bases. Sometimes you have to make incredibly difficult choices on what to focus on, what we can support, and what we should advocate for. Another strong branch of MSF is indeed advocacy. There is the MSF Access campaign, which has now been existing for more than 20 years, which argues consistently and non-stop in a very honest way about equity of medicines, the sharing of knowledge on how vaccines are produced. And I hope to give everybody a kind reminder, the current generation of RNA vaccines, these were not fully developed from scratch by the pharmaceutical industry. They came from our universities. They came from our public health institutes. They were developed with the best of intentions to improve access and serve health. And now they have become monopolized, in part as a business model. And I'm not saying that pharmaceutical industries are bad per se, because sometimes we need them to scale up to the levels that we need. But at the moment, the way that knowledge is not being shared is completely unfair. And that's also something that you see in a crisis. A crisis has the nasty tendency to always expose our inherent weaknesses. And it also comes down, unfortunately, in a sad reality of one lesson to be learned in this pandemic, that countries cannot be dependent on charity. They need to guarantee, to the best of their ability, their own health security. That also come, of course, with the investments in the basics, what has been mentioned before, in resilient health systems, and it should be a top priority during and after this pandemic. And this really also, in my picture, and I'm probably preaching to a known audience as a field epidemiologist myself, proper investments in field epidemiology training programs, but also the public health microbiology programs. But it also invites to a critical systematic reflection on why knowledge on life-saving pharmaceuticals, but also diagnostics, is not shared. And it's really the time to have this debate in an honest, scientific, and systematic way. Now, new variants emerge over time. We know that for COVID, every 3 to 6 months in this pandemic, we had new variants that took a dominant place on the world stage. The properties of these variants can differ. Sometimes they're more transmissible, sometimes they cause more disease, sometimes they cause less severe disease, but they are more transmissible, which is of course also a dangerous effect. And I went to the GSAID database, where scientists all across the world try to the best of their ability share the genetic information of these viruses. And this figure deserves some explanation. Here at the bottom, you see the start of the pandemic in December 2019, up till, let's say, 2 weeks ago. And vertically, you say all the different variants clustered here. So we start with the Alpha variant, and then we have here the Delta variant. Over time, it became dominant, and here the Omicron variant. And the reason why I mentioned that we also need to invest in our public health microbiology is because this way we can keep track of the spread of new variants. And I put it in an animation, and hopefully it's going to work. You can see that how first we had the Alpha variant, and then Delta started to emerge, but it only became visible later in the pandemic. The blue circles you can see worldwide. And as time moved by, the Alpha variant disappeared and the Delta became dominant. And then Delta was around, but it's now being pushed away, of course, by the Omicron variant. And you can see in the rapid pace that Omicron is really pushing itself to dominance on the world stage. That has frightened us a lot, especially in the beginning of December, and of course made many governments panic at the time. So around the Omicron variant, there are knowns and unknowns. The knowns is at this point in time, we know that Omicron is milder in disease, and we also know that Omicron spreads faster. And the sad reality, of course, we only learn this when we have cases. So sometimes we need to wait until people get infected, and we need to wait until they get in the hospital before we learn things about these viruses. But there are not huge differences in disease patterns there for those higher at risk. Although in many countries here in the north, we see that also young people are getting hospitalized, but that is a sum mostly of the huge number of infections and the fact that the younger populations are also at this moment the ones who are least vaccinated. And as I mentioned, the faster spreading variant can sometimes be worse than a more severe variant, especially for those unvaccinated and immune compromised. And in large parts of the world, we have big populations that are unvaccinated. And you see, for example, in countries like the Netherlands, where I am from, that we have people who are, let's say, lower on the socioeconomic index, where there is huge gaps in vaccination coverage. And you see many people being hospitalized from these specific areas, our vulnerable populations. There are also unknowns. And the unknown is this really the last obstacle towards the end in the pandemic? Are we now at this endemic stage? Well, to answer that, we need to answer first a few other questions. What do we mean with endemic? How long will immunity last? And what about new variants past Omicron? Well, what we mean with endemic, a really nice paper was just released yesterday in Nature, which was an editorial which I really recommend you to read. The statement of this author, Aris, is that rosy assumptions endanger public health. Policymakers must shape the years to come. Because when we talk about endemic, we mean some state of stability. If you look at the exploding numbers, there is no state of stability at this moment. We see rapid increasing infections across most regions in the world. So it's not a static situation. Endemic doesn't mean mild. Other diseases are also endemic, but not mild. Malaria is considered an endemic disease. Mortality is over 500,000 people a year. Tuberculosis, HIV, with respective 1.5 and 1 million deaths a year, are also considered endemic diseases. So when we talk about endemic, we really need to push out to our policymakers, but also to journalists. What do you mean with endemic? And really explain that endemic doesn't mean that the disease is gone. It means it has some form of stability and predictability, but the disease can still have a large health impact. So are we using then these policymakers the word endemic to normalize actually what should not be normal, in part also fueled by the fact that many people are tired? Immunity is the second question. We know that vaccines continue to protect against severe outcomes of disease. We also know that this immunity can be waning. That's why many countries started to have that privilege, the booster campaigns. We don't know how long lasting this protection is, especially for those highest at risk for disease outcomes. The same goes, of course, for people who get a natural infection. From the MERS coronavirus, we know that mild infections often lead to not long-lasting antibody-mediated immunity, but there is also strong indication for people that long-lasting T-cell induced immunity does not always offer similar protection, especially in those elderly people. Better adapted vaccines that will come around the period of May, of course, will help with that. Now, what's maybe also good to know, if Omicron would not have been here, maybe the image of the pandemic would have been different. The same would go for Delta. If Delta wouldn't have been introduced to the stage, then the pandemic would have looked very different, and we probably would have reached a stable endemic state already. And that's the whole question now. We don't know what's going to happen in the future, but there's two things that we know. High levels of transmission, gaps in vaccine coverage globally will give rise to new variants. And there's always a chance that this is a variant with more negative properties. And if you look again at this image that I cut off, you see here, you have the alpha variant, which existed very much in the beginning. And there was a branch, which means that they are less familiar to each other, that caused Delta. But this Omicron variant was actually linked back to the Alpha variant back in the age, which kind of shows that these variants can really come into existence at random and fly under the radar for a long time until there's an opportunity for them to rise. And that again adds to the unpredictability of disease evolution. So what that will bring for the future, we don't know yet. So are we towards an endemic stage? Not yet. And you see that also being echoed by the WHO, but also other professionals saying that. And it's a very hard narrative at the moment to say we're not there yet, because everybody wants to be at the end of the pandemic. So the goal should really be keeping infections low, ensuring that we can keep vaccine uptake high, to learn, to prepare, and keep on investing in our health systems and our people. We should always hope for the best. We should sketch the perspective, but hope is not a strategy. Okay, moving to the conclusions. A lot has been learned in this pandemic, but also nothing much new has been learned, I unfortunately have to say. Interaction on a community level. And when I say communication, I don't mean us speaking to communities. I mean a meaningful dialogue with our communities and our community leaders. Invest in the things that we know that work, like field epidemiology training programs, the public health microbiology networks. These are nothing new. We have seen horrendous levels of inequity. And these are bad things. But what I've also seen is how good we are sometimes in bringing us together, which is not easy work. It's a full-time job to bring the right people together. And networks such as MFNet, GORN, and TEFINET should get also a bigger role here to bring professionals from different countries together. And at the start of the pandemic, we were all struggling to write our own protocols, to find the latest evidence. There was nothing. And I think many of these networks played a big role in exchanging information in very informal ways, which is fast and efficient. So the question is really, how do we do better? All these lessons, how do we implement them better? How do we advocate to our policymakers that when the pandemic is over, they don't just go to rest, but they really invest in all these programs in a good way? The pandemic is not over yet, not yet. Even if it was, there is much work to do. After every crisis, a recovery phase follows, and we find always that there is a lot of damage that we didn't see before that has occurred to our societies. And we have focused on COVID, but all the other infectious diseases, all the other problems in society, they didn't disappear. If anything, they got amplified. And the way we face this pandemic, because COVID was not Ebola, didn't have that fatality rate, fortunately, but for me, it also brings a lot of worries about planetary health and climate change. The impact is not very direct. You don't see it direct tomorrow in your day-to-day life, but it's like this slow burning fire that we ignore. And at one point it's there and you can't ignore it anymore. So also for us as public health professionals, this will be, the important lessons from COVID to apply on the crisis of the future as well. So thank you for having me. It was an honor again to see you all. So the word back to you, Dr. Manet and Dr. Faris.
Thank you so much, Dr. Amrish, for the great presentation and all these great thoughts for the coming time. And a lot of points had been raised, and hopefully we are going to tackle some of them at the wrap up at the end of this webinar. But just to get use of the available time, allow me to introduce our third speaker for today, Dr. Haytham Awadallah. And Dr. Haytham is an assistant professor of community medicine at University of Khartoum in Sudan. He is a public health consultant and academic. He is a scientist, lecturer, and researcher with more than 15 years experience. And Dr. Haytham is an expert in the domain of health system and hospital management and healthcare quality. He has worked in various positions in the Ministry of Health, and very recently he is elected as the Minister of Health in Sudan. So we will say congratulations, and may God help you in this great and great mission. Inshallah, you will say all the success. Dr. Haytham, the floor is yours. I know that you are still in the car, so we are going to present from our side the slides, and you are going to comment, right?
Okay. Welcome, Dr. Mohanna, Dr. Faris, Dr. Maha, Dr. Amrish, and thanks for Infinite for organizing these useful webinars, adding to the library of COVID-19. This is in addition to its great contribution in public health in the region. And thanks for the first understanding the long-term impact of COVID-19 on the health system. Next slide, please. In this talk, we are going to structure our talk around these areas: the health system model, what has been already reported about the impact of COVID-19 pandemic on the health system in the world, reflecting on experience from Sudan, and end with expected long-term impact on COVID-19 health system. Next slide. Next slide, please. Next slide. Okay, thank you. This is a framework around which we are going to structure our talk. World Health Organization health system building blocks. We all know that these 6 building blocks are all active. Whose primary purpose is to promote, restore, and maintain the health all around the definition of health, continuum definition of health. The 6 building blocks around which, the 6 health system building blocks from the base. The previous slide, please. The leadership, the governance, and ending with the health service delivery, which sites the hospitals, the primary health care programs attached to the community and the individual. This is the first component of the health system building blocks hit by the COVID-19 pandemics, and the effect of the health of COVID-19 pandemic affects all the health system building blocks up to the governance and the health system. To start with, this next slide, please. To start with, next slide, please. Next slide. Is it better to share from our side, my side here? Next slide. Next slide.
I think Haytham has
Next.
delay, so
It is there,
Slide,
Dr.
please.
Haytham.
it takes some time to appear for him.
Dr. Haytham, this is like the slide for the malaria, TB, and HIV. Yeah. Oh, sorry.
I think it's better if he can share his presentation. I think, and if we give him the control over his presentation.
I think he's disconnected now. Dr. Haytham, are you still there? Yeah, you are back.
Sorry,
Dr.
I think
Haytham.
I missed connectivity for a while. In the next second slide. Okay. Slide share and next slide. Third slide, I think.
Slide 3, Dano.
The previous one, Haytham. The previous one. The previous slide.
Dr. Haytham, I think in His Excellency, he means the one with the malaria and
The
Disruption of services. The one before this as well.
Slide 5, I
Yeah.
think, done. Mhm.
Okay. Or you give me the permission to share from here. The service delivery, malaria, HIV, as I said that COVID-19 pandemic start by affect service delivery area, the programs, the hospitals, the primary health care. And it's clear that, for example, the slides regarding the HIV, malaria, and tuberculosis, all the health services related to these three diseases has been affected by COVID-19 in sorry.
Yeah, Dr. Haytham, we can hear you. Can you go on, please?
Yeah.
Your Excellency, would you like to control the slides from your side?
Okay, continue from your side. Continue.
Okay. Dana, please take care of that. Dana.
Okay. Okay.
Excuse me, which slide?
Okay. The previous slide. Okay, we can start from this slide. Okay, we can start from this slide. As I said in the previous slide, the COVID-19 has affected the health system, affected the program, affected the HIV program, malaria program, TB program, the uptake of the services, the diagnosis of the services, the treatment of the services, and also affecting the routine services and disrupting the health system. As stated here, the report, the recent report of Information of Pulse survey shows that the disruption of the health system almost reported in 94% of the countries contributed in this report. And 34% almost reported that the disruption above 50% in these countries. And this is very clear on the right side that the disruption in the routine services regarding immunization services, the uptake of the coverage of vaccination, the presence of health personnel, the deployment of the vaccines, all these are affected and other routine services affected during COVID-19. Next slide, please. Okay, there. In addition to these services affected, also there is an other positive and negative service has been affected. For example, as mentioned by the previous speaker, the expand use of telehealth and innovation in this area, and use of remote consultation and remote treatment, and as clear here, many of the countries worldwide have enhancement in these technologies. In addition to promote of home care services, in particular for chronic diseases like diabetes and hypertension and home care. In addition, for example, rational utilization of the health facilities between brackets. For example, during these areas, as observed in Sudan, for example, less bypassing of primary health care, and most of patients usually having simple symptoms, very mild diseases, they used to come to secondary care and to the hospitals. And during the COVID-19, because they are afraid of getting infection from the hospitals, they go to the primary health care. I think this is a good sign in a way, but also it is a bad sign in another way. But at least most of simple cases go to the primary health care, and this is noticed in Sudan, for example. In addition to promotion of health system research during this area, in addition to the biomedical research. Next slide. This is, in general, summarizing the positive and negative impact of COVID-19 on the health system over the last 2 or 3 years. For example, the positive ones like promoting teleservices for NCDs, for example, strengthening the coordination between parties, as mentioned by Dr. Mahar Rabat, improving the capacity of health staff, in particular in some areas, like, for example, infection prevention and control, hand hygiene, adherence to protocol, case management. There is, it is observed that there is the training of the healthcare personnel over the last 2 years. Many training programs has been conducted in this area, and the uptake of the protocols and the case management guidelines and directives taken seriously by the staff. And this, I think, it is a good sign. The capacity to mobilize dormant resources within the country and within the national and within the global to consolidate and to at least ensure some sort of equitable distribution of the services to prevent all population in the world from COVID-19. Strengthening capacities in surveillance, in international health regulation, in emergency care, in research. This is also clear, despite that COVID-19 hit very severely the health system. But this sensitize our system that we start to strengthen and research capacity. Also, realizing importance of public health roles by the public community, or by clinicians, or by the health system officials, or by the country directors. They get to realize the importance of public health roles in promoting the health of the community and maintaining the health of individuals. On the other hand, also there is many negatives could be summarized, like, for example, overwhelming of the health system, particularly the hospitals and the intensive care departments and HCDUs. Country like Sudan, for example, during the start of COVID-19, the total number of ICU beds with ventilators not more than 200 or 300. And you imagine that the number of cases is getting up, and this is only the number of ICU beds only in the capital of the country and big cities. Currently, the positive thing, this capacity of intensive care has been doubled or tripled in Sudan during the COVID-19, in response to COVID-19. This, on the other, on one side, strengthening the health system and the capacity of the emergency care, and the other side, reflecting the exhaustion and overwhelming of the health system and emergency care in Sudan. Other negative, very prominent, is discontinuity of routine services, like immunization program, for example. Not only immunization and primary health care services has been affected, but also the routine clinical services in the first first wave of the COVID-19. Even the routine surgeries, the routine antenatal care, the routine follow-up of the chronic patients affected, particularly during the first COVID of the first wave, because most of the healthcare workers at that time get panic like other communities and leaving the hospitals and leaving their clinics. Others than like creating parallel system at health system delivery level.
Your Excellency, is it possible to conclude within 2 to 3 minutes, if you don't mind, just to spare some time for the questions and answers?
Faris, I think he's disconnected.
I
and
think
maybe-
he's disconnected. Yeah. So I think we can go ahead with the questions and answers now, because I think we are left with only 15 minutes. I will give the floor, after your permission, to Dr. Mohanna to run the session, or to the questions and answers that I can see down here. Dr. Mohanna, the floor is yours, please.
Thank you very much, Dr. Faris. And here I have a few questions, but we can start with the Professor Dr. Maha. So the question is related to how we can develop an ideal approach to control a pandemic in the future, how we can improve our control measures for any future pandemic.
Well, thank you very much, Dr. Mohanna. Thank you for the presentations, and were really enlightening. And I really would like to answer the question, but before I want to comment on two things Dr. Amref said, and it's about respecting the context of the countries when we're asking them to really abide by, by adherence to measures. So there is a context that we need to really respect and to really absorb and contextualize. I mean, things that really has to manage the circumstances, the experiences, the resources, and this is really important as well. And another thing that I would like to add is that not every country has the starting point as the ending point like other countries. So we have different contexts that we have to respect in our response. For the health security part and for the preparedness part for future pandemics, this is what the WHO and the international organizations are working on now. It's the health security part. And it is building the resilience of the health systems and health security as part of this resilience, not only for the COVID, but for all emergencies that are expected to arise in the coming future. There is this international treaty as well, which is being approved by many countries, and they're working on it in order to not to modify, but to strengthen the international health regulations as well. So we have things at the global level and things at the country level, whereby health security, for preparedness, for surveillance, for data, for they have to be integrated within the resilience and the strengthening part of the health systems. But this requires a new oversight of how things need to be organized and how sources need to be allocated. And now we know that there is no development without health. So health is the face of the coin for any advancement in any interventions or in any development. So health has to be properly funded. It has to have the allocated resources and the integrated pattern of a health system with the health security part at its heart, the public health measures at its heart, and we need all to align to all of those aspects. Thank you very much.
Thank you very much, Dr. Maha. So back to Professor Amrish, and the question here about, I think it's about vaccine equity and how we can bridge the gap in vaccine availability, especially in low-income countries. So how we can face this challenge. Please, Dr. Amrish.
Yes, it's a complex question, and it's a complex question, not from, I think, a moral ethical point of view. From a moral ethical point of view, is something we need to do. We shouldn't discuss this, but it's more of like the question around, in part people make it legally explicitly complicated to share knowledge, for example, or to share vaccines. For example, countries that had overstocks of vaccines were not allowed to share them bilaterally because they would be responsible for the legal implications. So many countries, which is completely unimaginable, but prefer to destroy the vaccines than to share them. And in other ways, it's also a matter of like, okay, when we generate knowledge and technology with the best of intentions, how can it be that it's capitalized in such a way that this knowledge and innovation is not shared to the whole world? And I think for us, there is an understanding that COVID has revealed this. It has made it visible to the world, but it was always there. In the start of the HIV epidemic, it was there as well. And I think it's our joint task as public health professionals to start asking the right questions. Why is it so difficult? Can we please do a systematic analysis what the bottlenecks are in increasing the systems? I think India has, for example, showed in the 70s that they could do it, but they were a very big geopolitical nuclear power who could stand against the geopolitical might of big companies. And they said, listen, my population is dying of hepatitis B. We need these vaccines. Can you share the knowledge? The company said, no, we're not going to share the knowledge. So they said, okay, then we just develop our own vaccines. We don't care about the patents. We're just going to do it. Nowadays, they are the biggest supplier of vaccines in the world. Affordable vaccines, I must say. 70% of those vaccines are shared. And this we can repeat. This we can do again, this we must do again, because we're not talking about the patents and knowledge of the new model iPhone. We're talking about life-saving medicines. So it's also sometimes about finding the joint courage to address this issue and moving together. I think that's an important thing. And WHO does a great job, many regional networks. MSF has also been doing it for years. We need to unite the voices and really show that this is not the way we can continue.
Thank you. Thank you very much. This is very, to the point. Thank you very much, Dr. Amrish. So moving to Dr. Haytham, Your Excellency, you mentioned something about, the effect that was, the negative effect toward, immunization routine services during, the pandemic or COVID-19. So what we have learned from this experience after 2 years, and today we are facing Omicron. So how we can, the best scenario to manage such a challenge and to not repeat, at the beginning of the pandemic, we closed all the primary health services or majority of the primary health services. So what we have learned to avoid such an interruption in our healthcare or our health system in general, please.
Thank you, Doctor. And sorry for inconvenience regarding internet connectivity. I think this is a very critical and good question, because that, yes, we face this pandemic hit the health system, but at the same time, the most dangerous, and we miss a lot of people due to death is call this not COVID rather than COVID. And I can structure my talk like, for example, the first wave, during the first wave and the second wave, and along the way, at the start of the pandemic, the healthcare professionals, like other community, they get panic, they get afraid from the infection. They left the hospitals, they left the primary health care, even the primary health care, the antenatal care, the growth monitoring, the vaccination centers, even they left everything, and they stay at home. And one of the dangerous the misinformation epidemic during the first wave, that people get panic and left the health centers. To get back, we have there is a great effort was done through the media, through education, through the training, that this illness is not so serious. Yes, the mortality is less than 5%. It's like other SARS-CoV. Always say to the healthcare professionals, you should deal with every patient at COVID positive, or every
Okay. So it seems we have a problem with the internet connection from Sudan today. So until getting His Excellency back, Professor Maha, we have a virus question from the region about, We talked about, availability of the vaccine, but also we have another challenge related to the hesitancy and the resistance and refusal of the vaccine. So could you please elaborate more on this point, please? Thank you.
Well, thank you very much, Dr. Haitham, Dr. Mohannad. This is really an issue and a challenge for the vaccine. So we're always talking about the supply, the procurement, but we're really we are overlooking the situation of the acceptance of vaccine and vaccination. And this is the second part, because you always need two parties, you know what I mean? And you provide the vaccine and the supply, but you need the uptake from the people. And this is what we have said, it is the whole government and the whole society approach, how we are approaching the societies, empowering, engaging them. And it's the way of, because this is an emergency, it's not like we're changing the behaviors for the practices only, but it is just reaching out to them with the true messages, with the true information, with the communication narrative. And it is the trust and how you build the trust of the communities and the societies, particularly now that we're talking that there are different age groups who could be vaccinated, let's say, for the children and the youth, and it's reaching out and seeing the full and truthful and transparent messages delivered to them in a way that is acceptable to them. And here I would like to emphasize one issue. Communication as well has to be tailored to the culture, the context, the knowledge of the societies and the people, because our starting point in the communication is not the same. We do not stand at the same level for the information and the knowledge. So we need to work harder on reaching out to people, and this requires a planned strategy and the utilization of all the resources, all the stakeholders to reach out to people, listen to them, understand them, and at the same time to be as transparent with the messages in order to build the trust as well in the system that is providing the services for the vaccine and otherwise. Thank you very much.
Thank you. Thank you very much, Professor Maha. And here we have an interesting question to Dr. Amrish, that with all these uncertainties about the COVID-19 pandemic, shall we start learning to live with the disease and adapt our lives accordingly for longer time? So you presented very nice presentation with a lot of uncertainties. So how do you advise message for us? Yes.
Yes, I mean, living with the virus, we have to. But living with the virus does not mean that we act like the virus is not there anymore. Because that is a mistake you see being made, for example, in the UK at the moment, where they've decided to get all measures relieved while the tension in the hospitals is still high. Maybe the impact is good acceptable, but it's also a question of morality and ethics in your society. I remember discussions in our part of Europe here with people saying, it only affects the elderly, should the young suffer? And I think it also is very much a conversation about values. Like I think in our cultures, we have a different maybe perception of what an elderly person means for our families in the connection. And maybe in some countries or some regions, I think a little bit differently about that. Living with the virus means that we need to think in scenarios. Yes, we might go to an endemic scenario, but it might also be that a new variant comes up to surface. And then we need to act, but we need to act faster. We cannot wait. We need to invest in the basis, which is for the countries that can afford it. Test, trace, isolate, as the WHO has always been pushing for. That's like what we call the dike, the first barrier we have before we go into other measures. And investing in test infrastructure and testing and contact tracing is almost in every outbreak that we know a pivotal step in breaking chains of transmission. And it comes down again to what has been mentioned over and over by us all here, is the investment in resilient health systems. And people might say, but why are we investing so much in COVID? No, we're not just investing in COVID. If we invest in our health systems, we invest in better health for everybody. And I think that thinking is also in our task to put on the advocacy agendas, because people think only very, bilateral. It's COVID, but it's not. And I think that is really something we have to push for and to put on the agendas. People are tired, and we cannot blame that they are tired. But we have to tell them at times where it's possible, we'll have relatively near normal as we know it from the history living, but there will also be times when maybe we have to put some measures in place again.
Thank you. Thank you very much, Dr. Mbe. Back to Professor Dr. Haytham, and the question back to the related to the health system. Would the current pandemic induce a revision of the current structure of the health system?
Of course, we have much lesson learned from COVID pandemic. COVID pandemic, when comes, for example, developing countries, most of them has disrupted health system and very weak health system. And with the time start to recover, strengthening their system, strengthening their surveillance programs, strengthening their governance, strengthening their partnership. But I think we need to go to a new normal rather than back to normal. A new normal. For example, regarding the health service delivery, for example, at the start of the beginning, and as I said earlier, that there is a parallel system generated. COVID hospitals, non-COVID hospitals, COVID staff, non-COVID staff. This needs to be integrated within the health system again, to be part of the health system, but not as normal as before. I just said by Dr. Amrish, we need to consider that virus is there, not back to normal, putting off mask, leaving the standard precautions. We need to go back to a new normal, strengthening the use of IPC, infection prevention and control programs, the use of general precautions. And this is a lesson learned not only for COVID, but for all infectious diseases in the hospital and hospital-acquired infection. This is a good lesson. Hepatitis B, HIV, tuberculosis, or communicable diseases should have same lesson. I think we need last to strengthen our primary healthcare. Primary healthcare in all the times during pandemic, during the outbreaks, should be our solutions for our communities. Thank you.
Thank you
Over
very
to
much.
you, Dr.
Thank you very much. And I think, this is something very, very interesting, to talk and maybe in a special session about primary health care during COVID-19 pandemic. Lessons learned, maybe. This is something that we need to consider. So thank you very much. I hand over to Dr. Faris to conclude the sessions. Please, Dr. Faris.
Thank you so much, Dr. Mohammed, and thank you for all the speakers for the great presentation that they made today. Really one of the excellent topics that had summarized what had been done and what we saw during the last 2 years by the Professor, Her Excellency, Dr. Maha, and what is going to happen in the coming time and how this affect the health system and the collateral damage, unfortunately, we frequently see during the pandemic. So a lot of great points had been raised, really. And we'd like just to highlight it, if you allow me, just from my side, the absorptive capacity really in our region. I think one of the great issues that we have to look for indeed. Unfortunately, we in many of our countries, if there is some sort of postponement of shipments of the vaccine, we cannot consume the available vaccine, which is unfortunately it is something which is unexpected. We expect to have people looking for the vaccine, but unfortunately this was not the case. That's why in many countries in the Middle East there was some stagnation of the vaccine coverage, unfortunately. Thank you for the Professor Maha, and thank you, Dr. Amrish. Thank you so much, Your Excellency, Dr. Haytham, for your time. And I will give the back to Dr. Mohammed to close the session. Thank you.
And thank you once again, and it's our pleasure to have you with us today. Thank you for our attendees from different countries from the region, and I think it was very successful webinars, and we're looking forward having more such a very informative and very in-depth discussion for the future. Thank you all, and wishing you a very nice evening and night. Thank you very much.
Thank you. Stay safe.
Thank you.
Stay safe and have a good evening, everybody.
Thank you. Bye-bye.
Bye-bye.